Good afternoon, dear students. Today we continue the cycle of lectures for Propaedeutics of Internal Medicine for third-year students. And today's lecture is for MM groups, second semester of third year. And now we are starting a new sub-cycle in Propaedeutics of Internal Medicine. We're starting several lectures about signs and symptoms or disorders of GI gastrointestinal system. And topic of our today's lecture is syndromes of motor function disturbances of esophagus, stomach, small and large intestine. Let's start our today's lecture. The plan of our work today is to discuss separately esophagus disorders, stomach disorders, and intestine disorders. And on this slide, you can see a picture with reminding for you structure, anatomy, and topographic anatomy of gastrointestinal systems and all organs that take part in digestion. First of all, let's talk about esophagus motility disorders. Let's give a definition. Esophageal motility disorders are many medical disorders causing difficulty in swallowing, regurgitation of fat, and spasm-type pain, which can be brought by an allergic reaction to certain foods. The most prominent one is dyspepsia. It is the most typical, the most often symptom in upper GI disorders. It may be a part of CREST syndrome. It refers to 5 main features. It is calcinosis, renal phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia. Here you see one of typical esophageal motility disorder. It is structural disorders that disturb going of food, going of contents through the esophagus. We name it achalasia or narrowing of esophagus. Here you see X-ray picture of barium contrasted X-ray. With the narrowing of part of esophagus. Note that broad big appearance of the lower esophageal sphincter with dilated barium-filled esophagus proximally to it. It is obstruction of esophagus in a level of lower esophageal sphincter. Types of motility disorders of esophagus. Dysphagia could be for solid only or for solid and liquid foods, or for both or just for solid. Solid dysphagia is due to obstruction such as esophageal cancer, webs, or stricture. Solid plus liquid dysphagia is due to esophageal motility disorder or dysmotility, either upper esophagus, myasthenia gravis, stroke, or dermatomyositis. Or it can be connected with lower esophagus, for example, due to systemic sclerosis, CREST syndrome, that include, I remind you one more time, calcinosis, renal phenomenon, esophageal dysmotility, sclerodactyly, telangiectasia, or, for example, due to achalasia. You remember previous picture. Here you see a barium X-ray 2. It is a response to amyl nitrate, a smooth muscle relaxant in the same patient with previous picture, with partial relaxation of the lower esophageal sphincter, allows some barium pass through into the stomach. You see that place of narrowing widen it a little bit, and piece of relaxation and accumulation of barium a little bit transport to the stomach. Causes. It can be primary causes of esophageal motility disorders like achalasia, like diffuse esophageal spasm, and eosinophilic esophagitis, like inflammatory disorders that lead to narrowing too. And it can be secondary due to other systemic disorders such as systemic sclerosis, Chagas disease, etc. And here you see an X-ray picture. It is esophagram of 65-year-old man with rapid onset dysphagia over the year. Although esophagram shows a typical picture of achalasia, you see on the picture it is the segment of esophagus. It is the same thing like a line. It is place of achalasia. This patient has adenocarcinoma of gastroesophageal junction. This is an example of pseudoachalasia, which reinforces the absolute need to esophagogastroduodenoscopy in patients with radiologic diagnosis of achalasia. Symptoms of esophageal motility disorders. It is difficult to swallow in liquids or solids. You remember it can be both variants dysphagia. It can be regurgitation, feeling of returning of some contents to the mouth. It is heartburn on the substernal feeling. It can be chest pain, and it can be even nearly like cardiac pain, nearly the same feeling. It can be atypical chest discomfort. In some cases, patients can feel vomiting, a sensation of something getting stuck, and in severe cases, it will be weight loss. And on the picture on the slide, you see the image with feeling like something in your throat. It's very often a symptom for such patients. And one more X-ray for you. It is esophagram demonstrating a corkscrew esophagus picture observed in patient with manometry, confirmed findings of diffuse esophageal spasm. Even previous picture you saw achalasia. Yes, they look like segment of esophagus, like a line. Here in such a little bit other form, it is looking X-ray picture of esophageal spasm. For putting diagnosis of esophageal motility disorders. In patients with primary motility disorders, we can put diagnosis due to results of physical examination, and often often it is unrelieving. Clinical signs of scleroderma in the proper clinical settings must be noted, especially skin changes. Yes, if it is secondary to some diffuse, some systemic process, you should find other systemic symptoms. A bedside swallowing change may be performed with a glass of water. For every patient with suspected esophagus motility disorders, you should check general nutrition and hydration if significant dysphagia is reported. And one more picture. It is response for amyl nitrate with disappearance of spasm on esophagus. One more time. You see picture with a spasm, yes, that block going of content of esophagus through it. And after using of amyl nitrate, you see disappearance of this spasm. We see a low esophageal sphincter that narrowed a little bit, but not disturb going of contents. And another methodic, I hope you remember it from Propaedeutics, from another topics. It named esophageal manometry testing. Yes, it is a manometer that check pressure, and it should be placed specifically in a lower esophageal sphincter or in zone of high esophageal pressure. And during some time, usually it is during day, it is checking of pressure in lower esophageal sphincter. Also it known as motility testing, and it used to evaluate a neuromuscular functions of the esophagus. The catheter with manometer is placed through the nose. It goes to the pharynx, larynx, and after it to esophagus. And the And the manometer should be placed in the region of lower esophageal sphincter to check pressure and acidity there. Okay, let's start a discussion of stomach motility disorder. Specifically, stomach can have different types of motility disorders. But before it, let's remind definition. Gastric motility disorders are any alterations in the transit of food and secretion into digestive tract. We can classify several types of stomach motility disorders. They include: it is delayed gastric emptying, or another name of it, gastroparesis. It is rapid gastric emptying, the opposite situation, or we name it dumping syndrome. It can be functional dyspepsia. It can be idiopathic vomiting and cycling vomiting syndrome. Causes of stomach motility disorders. There can include diabetes, infections, endocrine disorders, most often it is hypothyroidism, connective tissue disorders like scleroderma, autoimmune conditions, or neuromuscular diseases. They can be idiopathic when we can't find any cause, any significant cause, and in such case we name disease idiopathic. Different psychological conditions like depression, like psychiatric diseases, can lead to stomach motility problems. It is eating disorders, certain cancers, radiation treatment applied over the chest or abdomen, some chemotherapy agents, and surgery of the upper intestinal tract. Let's discuss all these types of stomach motility disorders. First, it is delayed gastric emptying or gastroparesis. Poor emptying of the stomach can occur for several reasons. The outlet of stomach, the pylorus duodenum, may be obstructed by ulcer or tumor, or by something large and indigestible that was swallowed. The pyloric sphincter at the exit of the stomach may not open enough or at the right times to allow food to pass through. The normally rhythmic 3 per minute contractions of the lower part of the stomach can become disorganized so that the contents of the stomach are not pushed toward the pyloric sphincter. Here you see different diagnostic symptoms. It is X-ray and endoscopic picture of delayed gastric emptying or gastroparesis. On picture A, it is X-ray, simple abdominal X-ray that shows dilated stomach with food material. And really on this picture you can see that stomach is enlarged and contains a lot of food. Picture B, it is endoscopy with severe stenosis of anastomosis site after bilirubin 1 gastroduodenostomy. It is after surgery complication with obstruction of pyloric region and gastroparesis. Opening, it is in an inferior direction of anastomosis sites. Opening was too small for endoscope to pass through. Ulcer lesion is seen below anastomotic site. And picture 3, picture C, here you can see a treatment way of this situation. It is endoscopic view of gastroduodenostomy stenosis undergoing balloon dilatation. If those places was such narrow, if we can't even go with catheter, we can use a balloon to widen it. Balloon dilation by 20, 25, 30 degree of pressure was done for 2 minutes. There developed no complications such as bleeding due to procedures. Widening of stenosis site can be seen, and you see this procedure on picture C. And the opposite situation, if those was too low, emptying of stomach. Here it is a rapid gastric emptying, or another name of these disorders I told you, it is dumping syndrome. Rapid gastric emptying or dumping syndrome happens when the upper end of small intestine that we named jejunum fills too quickly with undigested food from the stomach. If it was not enough time for normal digestion in the stomach, that's why a lot of undigested food goes to the jejunum. The dumping syndrome can be early and late. Early dumping begins during or right after the meal. Late dumping happens 1 to 3 hours after eating. Many people have both types as symptoms of early dumping as symptoms of late dumping syndrome. Here you see a typical picture for gastroparesis. And next syndrome, it is functional dyspepsia. Why it different from two previous types? Many patients have pain or discomfort like fullness, early satiety, feeling full soon after starting to eat, bloating, nausea that is felt in the center of the abdomen above the belly button. There is no single motility disorder that explains all these symptoms, but about a third of patients with these symptoms have delayed gastric emptying, usually not so severe that it causes frequent vomiting, and about a third show a failure of the relaxation of the upper stomach following a swallow or abnormal gastric accommodation reflex. About half of the patients with these symptoms also have a sensitive or irritable stomach, which causes sensations or discomfort when the stomach is filled with even small volumes. And pathophysiological components of functional dyspepsia is probably it affected by visceral hypersensitivity, by disrupted gut immune interactions, by the abnormal upper GI motor reflex function, by psychological factors, genetic factors, and altered brain-gut interactions. All of them, like risk factors, can lead to functional dyspepsia. And one more time, it is dyspepsia which disturb patient with cause a lot of different symptoms, but we can't find any organic causes like gastroparesis or dumping syndrome or gastritis or ulcers or any other causes that we can see or can touch, and all labs will be normal. That's why it is specific motility disorder, but it's no physical changes during patient's investigation. It's just, but it causes serious symptoms. Another syndrome for today, it is cyclic vomiting syndrome. Cyclic vomiting syndrome is a disorder with recurrent episodes of severe nausea and vomiting interspersed with symptoms-free periods. Cyclic vomiting syndrome occurs in all ages. It can be in children, it can be in adults, it can be in aged people. Patients may struggle for many years before a correct diagnosis is made. The main symptoms in general for all stomach motility disorders, as for dumping, as for gastroparesis, as for cyclic vomiting, functional dyspepsia, for all of them in general, it is the most typical symptoms. They include nausea or vomiting, retching, we name in such way dry heavies, bloating, upper abdominal pain, stomach fullness after the normal-sized meal, early fullness, satiety with inability to finish a meal, weight loss due to a decreased appetite. Gastric motility procedures that help us for diagnosing different stomach motility disorders. One of the most informative, it is Smart PET wireless motility capsule. It is a modern way of endoscopy, but not with catheter like in upper endoscopy. We use a pill that contains camera and processor and can fix during its going picture and video of all parts of GI tract. It is a pill-sized sensor that is swallowed by patient and measures temperature, pH, pressure, how quickly the stomach empties, how quickly the small intestine and colon empty. Okay, next way for testing, it is H. pylori or Helicobacter pylori testing. H. pylori on practical classes you will discuss more about it. It is one of the important pathophysiological links and causes etiologies of different GI disorders. That's why testing for Helicobacter pylori is very important in diagnosing patients with GI problems and specifically with stomach disorders. It can be done with a blood antibody test, with a breath test, stool antigen test, or stomach biopsy. In all these variants, it can be done H. pylori testing. Breath testing can help detect a food intolerance, bacterial overgrowth, irritable bowel syndrome, fructose intolerance, lactose intolerance, and constipation. It is in such way looks a Smart pill wireless motility capsule. Yes, it is a small capsule that we ask patient to swallow. It consists of two parts. It is external part that is individual for every patient and internal part with a camera and with processor that send all signals and all parameters to the computer, and we can fix a lot of different parameters of GI tract. And H. pylori testing is the most simple way. It is a paper repeat testing. Yes, we make a sample, put it into the dilution and extraction buffer, fix there a paper strip, waiting for 10 minutes, and like for pregnancy, we can check is it positive patient or negative for H. pylori. And breathing testing according to accumulation of breathing out air, we can check a lot of different parameters. Okay, and what about intestine motility disorders? Let's give definition. What about intestine? The phrase intestinal motility disorders applies to abnormal intestinal contractions such as spasm and intestinal paralysis. This phrase is used to describe a variety of disorders in which the gut has lost its ability to coordinate muscular activity because of endogenous or exogenous causes. The mechanism you see here, most of them take its causes for the innervation and central nervous system. And disturbances of these interactions between extrinsic neural pathways and intrinsic nervous system can lead to abnormal innervation of GI and to motility disorders. First of all, intestinal motility. Causes seem to be multifactorial, the same with the stomach and esophagus, and only few have been detected. Different degenerative disorders cause pseudo-obstruction along with other problems. Some drugs that are commonly used, like 3-cyclic antidepressants, diuretics, laxative, or have specific indications. The drugs like lithium salts, vinca alkaloids, and other chemotherapy agents may interfere with intestinal motility. Several endocrine disorders, like the most often myxedema, can also cause pseudo-obstruction, and different genetic factors are supposed to be risk factors for intestinal motility disorders. Manifestation of intestinal motility disorders the most often goes with abdominal distension, with recurrent obstruction of GI tract, with severe abdominal colicky pain. It is quite often a symptom too. It can be severe constipations. It is GI gastroesophageal reflux disease and intractable recurrent vomiting. And on this slide you can see a scheme from the guidelines of 15 the most often causes of constipation, and constipation like a result of motility disorders. For constipation, you know that a huge number of people suffer from this syndrome. The most often it caused by poor diet, lack of exercise, medications, underactive thyroid or hypothyroidism, by IBS, perianal pain, neurological conditions, not enough water, poor toilet habits, stress, laxative abuse, bowel cancer, PT training, traveling, and pregnancy. And one of the most often it is IBS. It means irritable bowel syndrome, that is connected with our today's topic and have the same pathogenesis with functional dyspepsia. Clinical features of intestinal motility disorders include intestinal pseudo-obstruction, or we name it Ogilvy syndrome. It can be irritable bowel syndrome, IBS, what I told you. It can be fecal incontinence and constipation. In methods over the usual that I can show you, for example, here on previous slide it is typical simple abdominal X-ray, and you see that intestine are very widened. It contains a lot of stool. We can use more rare methods of investigations, like for example endoscopic ultrasound. You can see here on the picture. It is ultrasound when the operator of ultrasound put the ultrasound sensor on endoscopic tube. Yes, and we can visualize internal part of GI tract. And on this picture, like an example, we see anterior defect in internal and external anal sphincter. For intestinal motility disorders, we have classification for its form by author. It named Knowles-Martin classification, and it described delayed colonic transit, slow transit constipations. It includes enteric neuropathy, enteric myopathy, Parkinson's disease, endocrine disorders, and spinal injury. Another form, according to this classification, it is dilated colon that can be diffuse or segmental, and include Ogilvy syndrome and megacolon. And one more form, it is absent recto-anal inhibitory reflex line in Hirschsprung disease. All these forms are more digitalized. You should prepare for practical classes. For diagnosing of intestinal motility disorders, we can use GI scintigraphy, like on this example. In this 2-hour image, first image before 2 hours, a second after. Not for normal empty, like 31% empty. Normal range is from 31 till 67%. In the left image, with significantly more tracer shown in small intestine than in the right image shows delayed empty. On second image, it is 26% empty and much less tracer in the intestine. Symptoms of intestinal motility disorders. It is a pain in the abdomen. Usually it is diffuse, no located pain, nearly in the middle of abdomen in periorbicular space. It can be bloating, it can be disturbed bowel motion, it is feeling full after having eaten only a small amount of food. It can be nausea, can be vomiting and severe constipation. And you see here an interesting picture. Why I include it here? Because we don't learn treatment on third year, but on this picture it is the most effective way of treatment of intestine motility disorders. Here it is not a drugs, it is a lifestyle modification and specific physical activity. And here the physical activity like running or jogging at least 30 minutes 3 times a week can dramatically improve symptomatic in patients with intestine motility disorders. Okay. Another testing for diagnostic of motility disorders. Yes, it is endoscopy, and it can be lower endoscopy. And here, like an example, a placement of guide wire for motility catheter. Yes, we're checking of internal lower of intestine and checking testing for motility. Here you see X-ray with on second picture X-ray with a placement of colonic motility catheter. Yes, endoscopic view of this catheter, and second picture it is X-ray view of the same catheter. Physical examination of patients with intestinal motility disorders. A clinical picture of patients with intestinal motility disorders is protein and may vary greatly depending on specific condition present. Always perform a digital rectal examination in any patient with an intestinal motility disorder to detect the presence of a mass, like feces, tumor, or foreign body, or blood in the rectum. In all GI patients, ideally, in general, in all patients that you investigate, you should do a digital rectal examination. Okay, one more method. It is X-ray picture, or that we named defecography. And like an example, you see here on the first picture anterior rectal cell and anterior rectal cell that not empty. Okay, and two more terms that I want to discuss to you today. It is maldigestion and malabsorption. It is very often terms that you will meet during all your education and learning of internal medicine. They are very important. Let's give definition to these terms. Maldigestion describes the inability of an individual to digest food in the gut. Malabsorption is an inability to absorb nutrients which have been digested from the food through the gut. Okay, organs that can suffer from maldigestion and malabsorption. Yes, it is nearly all organs. You see it by the skin that sperm, kidney, liver, bone, lungs, brain, blood, heart, muscles, pancreas, egg. All these organs and all other organs can suffer from maldigestion and malabsorption, because from the GI we got all our nutrients, all our chemicals, and without necessary chemicals for organism, without its normal digestion and normal transport absorption to the blood, it will be suffering for all organisms. Causes of maldigestion and malabsorption. It is congenital heart disease. It can be cystic fibrosis. It can be gastroenteritis, kidney infection, liver disease, short bowel syndrome, toddler's diarrhea, etc. A lot of our conditions. You see that can be it can be GI causes and it can be non-GI causes. Symptoms of maldigestion and malabsorption. They can be gastrointestinal with GI manifestation and not gastrointestinal. Gastrointestinal symptoms of maldigestion and malabsorption include diarrhea, steatorrhea, who don't know, it is undigested fat in a stool. It is weight loss, flatulence, pain, abdominal bloating, abdominal cramps, abdominal discomfort, swelling or edema, and muscle cramps. Histological examination of biopsy, intestinal biopsy in patient with maldigestion and malabsorption. According to different causes, it can be from normal structure, like on picture A, the same with the different other clinical picture on different pathology on pictures B, C, and D. Symptoms of extraintestinal manifestation of maldigestion and malabsorption include patients with celiac disease, presence with anemia and osteopenia in the absence of classic GI symptoms. It can be microcytic, macrocytic, or dimorphic anemia may reflect impaired iron, folate, or vitamin B12 absorption. Purpura, subconjunctival hemorrhage may reflect hypoprotonbuinemia secondary to vitamin K malabsorption. Osteopenia is common, especially in the presence of steatorrhea. Impaired calcium and vitamin D absorption and chelation of calcium by unabsorbed fatty acids resulting in fecal loss of calcium may all contribute. Dermatitis and peripheral neuropathy may be caused by malabsorption of specific vitamins or micronutrients and essential fatty acids. Here you see a pathophysiological scheme of B12 deficiency anemia. One of the most often cause of it is maldigestion and malabsorption of vitamin B12, and its deficit can lead to macrocytic anemia. Complications. Both maldigestion and malabsorption can lead to deficiencies, for example, in vitamins and minerals, as well as protein and energy. The complications can depend upon which nutrients are affected. For example, a calcium and vitamin D deficit can lead to rickets and osteopenia. Iron deficiency is associated with anemia. Zinc deficiency has been linked to poor growth. Problems with absorbing protein, fats, and carbohydrates can culminate in weight loss and undernutrition, with wasting, in severe cases stunting. Here you see a result of malabsorption of vitamin D. Depending on what age it manifests, it can lead to osteopenia, for example, in adults, to growth deficit in children. Diagnostics of maldigestion and malabsorption. There is no one single specific test for it. In different conditions, it can be different. A range of different conditions can precede maldigestion and malabsorption, and it's necessary to look for each of these specifically. Many tests had been advocated, and some, such as tests for pancreatic function, are complex, vary between centers, and have not been widely adopted. Tests are also needed to detect the systemic effects of deficiency of the malabsorbed nutrients, such as anemia with vitamin B12 malabsorption. Here you see a scheme of malabsorption. Yes, when these problems with intestine epithelium, for example, due to inflammation, it leads to abnormal absorption of nutrients from the GI tract to the capillaries and to the blood, and abnormal function of microvilli in epithelium. Okay, blood test in diagnosing of maldigestion and malabsorption include routine blood tests or CBC. They may reveal anemia, high C-reactive protein, and low albumin. Microcytic anemia usually implies iron deficiency, and macrocytosis can be caused by impaired folic acid or B12 absorption, or both of them. Low cholesterol or triglyceride may give a clue toward fat malabsorption. Low calcium and phosphate may give a clue toward osteomalacia from low vitamin D. Specific vitamins like vitamin D or micronutrient like zinc levels can be checked. Fat-soluble vitamins like vitamins A, D, E, and K are affected in fat malabsorption. Prolonged proton beam time can be caused by vitamin K deficiency. Moreover, immunoglobulin A anti-transglutaminase antibodies or immunoglobulin A anti-endomysial antibodies for celiac disease. It is gluten-sensitive enteropathy. This is specific testing for this disorder. And here you see a detailed scheme of pathophysiology of fat malabsorption. Yes, with the main causes of it, with lymphatic obstruction, reduced small intestinal surface, and iatrogenic. That resulting in allergic eosinophilic gastroenteritis, tuberculosis or tuberculous lymphadenitis, and short gut syndrome. That leads to different changes in enteric epithelium with possible Whipple's disease, lymphangiectasia, for example, that manifests in Crohn's disease, in lymphoma, or, for example, changes typical for celiac sprue or tropical sprue. Stool studies. Microscopy in maldigestion and malabsorption is particularly useful in diarrhea. It may show a protozoa like Giardia, ova, cyst, and other infective agents. Fecal fat studies to diagnose steatorrhea is rarely performed nowadays. Low fecal pancreatic elastase is indicative for pancreatic insufficiency. Chymotrypsin and pancreauracil can be assessed as well. And you see the connection, pathophysiological connection between diarrhea and malabsorption. In the different level, in the level of jejunum, the mucosal resistance will be leaky. Spontaneous PD may be nearly 3 millivolts, and absorptive mechanism affected sodium nutrients and sodium water transport. And another changes in diarrhea in the level of ileum, cecum, in proximal colon and distal colon, according to changes in mucosal resistance, in spontaneous PD, in absorptive mechanism. We can do on what level and what the cause, the level of cause of diarrhea. And for your individual work, for your interesting, I have USMLE question for you. A 22-year-old female presents to your office with gas, abdominal distension, and explosive diarrhea. She normally enjoys eating cheese, but has been experiencing these symptoms after eating it for the past few months. She has otherwise been entirely well. She recovered without treatment. Which of the following laboratory findings would you expect to find during workup of this patient? And options. First, it is decreased stool osmolar gap. Second, decreased stool pH. Third, positive fecal smear for leukocytes. Fourth, positive stool culture for rotavirus. And fifth, positive stool culture for Tropinema whipple. It for your individual work who was attentive to today's lecture. Please try to answer somewhere in your conspect or, for example, in comments under the YouTube video. As usual, in comments you can write your questions. You can You can suppose different difficult moments and ask it for discussion in the comments or in our Facebook page. And as usual, I ask all students who listen in the lecture leave under the video in comments your name and group number. For today, that's all, and see you in 2 weeks in another Propaedeutics lecture that connected with other GI